Okay, this is just a routine cataract surgery. This is an unedited video. I'm just going to do a voiceover to explain my technique. Paracentesis is just a 1mm blade, and this is an epinephrine lidocaine mixture that will help with pupil dilation and comfort for the patient throughout the surgery. This is Endocoat, part of the Duet system from Johnson & Johnson, dispersive viscoelastic. And then my main incision is a 2.4mm incision. That's a 2mm long incision, and I extend it slightly because I find if I don't, it can be a little tight with the yellow sleeve that we use with the Johnson & Johnson machine. Capsulorhexis here is initiated with Utrata forceps and then completed without any trouble. I use that second instrument to stabilize the eye. Sometimes if the patient moves, that second instrument will kick in and sort of save the day. Hydrodissection is with an Akahashi cannula. I go all the way across the lens because sometimes when you inject the BSS, the lens wants to pop out of the capsule. Then the cannula is there to keep it in place. I just make sure that the lens is mobile before I start doing the phaco. Phaco tip here is the 20 gauge needle, I believe. That yellow sleeve is Johnson & Johnson. I do continuous irrigation, and I start that process while the tip is about halfway into the incision. That prevents the patient from feeling a big surge when the continuous irrigation comes on. Sort of a gradual ramp up. Otherwise, this technique is pretty much your standard divide and conquer. I don't use a lot of phaco energy. It's a lot more vacuum, but pretty old school standard technique. Nothing fancy. I don't do a lot of movement of the phaco tip. I mean, I don't go chasing things. I'll use that second instrument to bring the pieces to the tip. And then I use the Venturi pump on the phaco machine for this entire process. And that does a really good job of bringing the material to you. So sometimes it's sort of a grab and smash technique where I'll hold on to the piece with the phaco tip and use that second instrument to compress it into the phaco needle. Irrigation aspiration is pretty standard. Still use continuous irrigation, and so I'll start that process, as you can see there, right before I get all the way into the eye. This is the Alcon irrigation aspiration tip. It has that polymer tip, which is pretty capsular friendly. We have a metal tip in our other center. I sort of prefer the metal tip actually, but they're both good. This is Helon going into the capsule. This will facilitate insertion of the implant. Before I put the implant in, I'll do some capsule polishing. This is the Singer Sweep instrument, and removing the epithelial cells, I was always told, will help facilitate the healing. Most of the inflammatory cytokines and mediators are created by the epithelial cells in the capsule, and so removing as much of that as possible, I've been told, is beneficial. I use the second instrument to stabilize the eye. That funnel goes through the entire incision. This has never been an issue distorting the wound or making it difficult to close the wound, but it makes the insertion of the implant a lot easier. Otherwise, sometimes the implant will get stuck in the incision if you don't put that funnel all the way in. Once it's in the capsule, then you just release the haptics. Everything unfolds and centers pretty nicely. I hydrate the incision there with a cannula. This is Dexmoxy that goes into the vitreous cavity. That's dexamethasone and moxifloxacin that facilitates the healing process, helps prevent infection. To remove the viscoelastic, I go under the implant to make sure that it's all been removed from the capsule, and then I have a sort of a sweep technique there to try to get the Healon out of the angle, just try to prevent pressure spikes. Again, I use the Akahashi tip to hydrate the incision. That's the main incision, same with the paracentesis. And then I'll use a Weck to try to pull the fluid out of the interface between the endothelium and the rest of the stroma. There's just some gentle pressure there on the edge of the incision, trying to oppose those two pieces of tissue, because once the endothelium kicks in and starts to act as a pump, it will seal that incision and it'll stay closed. This technique has probably evolved over the years, but I think that the risks of the incision opening later go way down when you've closed it like this and the endothelium is fully active. Right now I'm just checking the pressure in the eye to make sure that it's about right. Implant is well centered, and then we put subconj Kenalog. This is just part of the dropless surgery, so these patients with the moxifloxacin inside the eye and the Kenalog subconj, they don't need any drops. And that's it.